Thank you, James. Yeah. So now I'm going to share my slide. Yeah, I didn't select the slideshow because I'm going to delete some slides. Yeah. So I'm going to talk about the health status of agents in Nebraska. Dr. Schiffer already gave us very detailed Nebraska populations data. I will not repeat that. So just want to let you know, agents was the fastest growing minority groups in Nebraska, with a 64% increase between 2010 and 2020. In the same time period, the white populations decreased. So what health issues Asians face? So major health concern for Asians Americans. Asians are most at risk for the following health conditions: liver cancer, stomach cancer, lung cancer, hepatitis B, TB, heart disease, stroke, unintentional injury, and diabetes. Asians have a high prevalence of following conditions and risk factors: chronic lung disease, hepatitis B, HIV, smoking, TB, and liver disease. Asians also have some negative factors, such as infrequent medical visit. Asians are the least likely to seek and receive mental health treatment and also other treatment. Language and cultural barrier, especially for the refugee population. Lack of health insurance. Here are top 10 leading causes of death for Nebraska agents. The leading cause of death among agents is cancer, accounting for nearly 30%. The second leading cause of death among agents is heart disease. COVID-19 was the first leading cause. What was the ninth leading cause among the agents? Compared with Nebraska data, compared with whites, even though cancer is still the leading cause of death for all the Nebraskans, heart disease is the second one, but actually for the statewide, the cancers, the percentage for cancer and the heart disease is very, very close. Both of them about the 21% something. Yeah. But the agents is a big difference. So now I have questions. What are the biggest disparities for agents? We will compare with whites. What is the big disparity for agents? Somebody maybe say heart disease and the stroke, diabetes. I just want to let you know this is not a disparity. These are leading cause of death. Now I'm going to talk about the disparities in Nebraska. So we always compare with white to identify disparity. Disparity ratios are calculated by dividing the rate or percentage for agent population by the white population. Ratios 1.1 to 1.4 imply there is a little disparity. Ratios 1.5 to 1.9 implies disparity exists. This health condition should be monitored and may require intervention, such as no personal physician, diabetes, inadequate prenatal care, liver cancer, living below the federal poverty level. Here are some big disparities for Nebraska agents. Disparity ratios 2 to 2.4 implies disparity requires intervention. Ratios 2.5 and above implies unacceptable disparity. This health condition required immediately intervention. TB, hepatitis B, without high school education and the stomach cancer are the biggest disparity for agents. TB was 33 times more common among Asians compared with white. Agents were nearly 10 times more likely to die due to the hepatitis B compared to whites. Agents nearly 4 times more likely than whites to have less than a high school education. Agents were twice as likely to die from stomach cancer compared to whites. Now we can think about what can we do to reduce these disparities, these big disparities. No disparity measures. We already know when we compare with other group, Asian populations actually they have few health conditions issues compared with other minority groups. Disparity ratios less than or equal to 1, no disparities. These key measures came from Nebraska Health Disparity Report. There are also some other indicators that are not included in this report. Key agents better off measures. Disparity ratios less than or equal to 0.5 imply agents better off. These health conditions are heart disease mortalities, chronic lung disease mortality, breast cancer mortality, prostate cancer mortality, unintentional injury mortality, motor vehicle accident mortality, suicide, alcohol-related mortality, drug-induced death, obese, depressive disorder, infant mortalities, binge drinking, heavy drinking. All these matter when we compare with white, the agents better off. Due to this presentation only about 12 minutes, I only have about 12 minutes, so I'm going to skip the following detailed slides and go to another topic. Okay, I'm going to talk about the Asian refugees in Nebraska. This table shows the top refugees population admitted to Nebraska in the last 10 years. 2 of the top 5 groups are from Asian countries, Burma and Bhutan. Nearly 45% refugees admitted to Nebraska in the last 10 years came from Burma. 18% refugees came from Bhutan. In order to identify the needs and the health related to the risk factors for Nebraska refugees, Office of Health Disparity and Health Equity partnered with Korean Society, Bhutanese community in Nebraska, Asian Cultural Center, and other refugee groups to conduct the first statewide refugee needs assessment. 123 questions was included in this survey. More than 60 bilingual interviews were treated in a series of 20 workshops. All surveys was conducted by face-to-face interview. More than 2,200 surveys were conducted in Omaha, Lincoln, Grand Island, Lexington, and other cities and towns across Nebraska. So here are 19 course sections was included in this survey. I'm going to share some results related to the language needs. Educational attainment. Nearly 26% of refugees, they never attended school or having only attended kindergarten. Over 65% have not graduated high school. Only 2.5% was college graduate. Biggest challenge. Language barrier was the biggest challenge reported by refugees. 72% refugees reported language barrier as the biggest challenge. English speak ability. Nearly 72% of refugees reported speak English not well or not at all. Understand verbal health information in English. Almost half of all refugees report it was very difficult to understand the information given by doctor or other health professionals in English. Understand writing health information in English. 44% of refugees reported it was very difficult to understand written health information. 10% do not read any written health information. Based on the data, we already completed 5 refugee reports. Nebraska statewide health data report, Lincoln refugee health data report, Omaha refugee health data report, Korean refugee health data report, Bhutanese refugee health data report. Here are the table of contents for Nebraska refugee report, table of contents for Korean refugee report, for Lincoln refugee report, for Omaha refugee report. All these reports are available on Office of Health Disparity and Health Equity website. We also have other reports related to the Nebraska agents population, such as Nebraska Disparity Report, Nebraska Agent Health Data Report, Nebraska Agent Social Determinants of Health Report. This report identifies the disparity and the need for Nebraska agents and the Nebraska agent refugees. We will work together to reduce these disparities and address the need for Nebraska agents and refugees. Thank you.